Okay, can we start now? Or are we waiting for the other students? Shayna, ilan lang kayo? Oh, we can start now, okay. Okay, let's wait for another minute, okay? Then we'll start. Okay, class, so let's start. So, can you see my screen? Okay, so good afternoon. Our lecture for today is about the liver. Okay, so please bear with me. I just have 40 slides. So this will, I think the lecture will take probably about 1 hour. Okay, so I am Dr. Bulatao. Okay, so these are the fixes after my name: PCS, FPSGS, so FPABS, meaning hepatobiliary and DPS. Okay, I'm also a hepatopancreatobiliary surgeon. So it's fitting that this is assigned to me by Dr. Renan. So our topic is about the liver. Okay, so as we all know, liver is the largest solid organ in the body. Okay, so it weighs 1.5 kilograms in adult, and it is surrounded by the Leeson's capsule. Okay, so the location of the liver, it is adjacent to the diaphragm, cephalad, and caudad, it is adherent to stomach it is close to stomach, duodenum, and colon. And posteriorly, we can find the right kidney and adrenal. Okay, so let's talk about segments of the liver. Okay. So in describing the location of a liver tumor or a liver injury, we make use of a system called Conard system. Okay. It is numbered 1 to 8. Okay? In order for the other clinicians to locate what tumor injury are we talking about, where is it is located. Okay? So the liver is grossly separated to the right and left lobes. by the plane from the gallbladder fossa up to the inferior vena cava, known as Cantley's line. So Cantley's line is the one dividing the liver in right and left, not the ligament, not the falciform ligament. Okay? So the right lobe accounts for 60 to 70 liver mass, while the left lobe, including the caudate lobe, making up the remainder. So majority of the liver is located in the right. Okay, so this is the segments of the liver. Okay, one is number 1 to 8. So we could see here posteriorly the gallbladder, okay, and the inferior vena cava. So it divides the liver into right and the left lobe. While for the falciform ligament, it actually divides the left lobe into left lateral and left medial. Okay? So, anteriorly, you cannot see the segment 1 because it is located posteriorly adherent to your inferior vena cava. So, that's how we locate the tumor or using the gonad system. Okay, let's talk about the blood supply of the liver. Okay, so what are the blood supply of the liver, Erin?
Doc, I think Irene is
Ano ba si Irene? Wala? Absent? How about Alvin?
oh,
Yes, Alvin.
in the portal vein.
Come again, sorry.
I think that's supply po the hepatic artery and the portal vein po. The hepatic
Okay, good. Portal vein and hepatic artery. Okay, so between the two, uh, which supplies the liver more, probably around 70% of the blood volume.
portal vein.
Portal vein. Okay, it's correct. Okay, so let's talk about first the portal vein. Okay, so it is a valveless structure uh, formed by confluence of the SMV and splenic vein. So we already learned this from our anatomy lecture. Okay, periomesenteric vein and splenic vein will form your portal vein. Okay, so it provides 70% of the liver's blood supply. The remaining is the hepatic artery. Okay, take note of this. It is located posterior to the bile duct and hepatic artery, but it is within the hepatoduodenal ligament. Okay? So together with the portal vein, together with the bile duct and hepatic artery, they are known as porta hepatis or portal triad. Okay? So there are three structures there in the hepatoduodenal ligament: portal vein, bile duct, and hepatic artery. Okay? Take note of that. Okay, so the normal portal vein pressure is 3 to 5 millimeter mercury. Okay? Other books will tell you it is 5 to 10 millimeter mercury. Okay? So, increases in venous pressure are distributed to the plaque circulation with the development of portosystemic bilaterals. So, in case of portal hypertension, okay, the pressure uh, elevates as high as 20 to 30 millimeter mercury. So this results in decompression of systemic circulation through portocaval anastomosis. Most commonly by the coronary from the left gastric vein, which produces the esophageal and gastric varices. Okay? That's why if you have already portal hypertension, your patient will have esophageal varices, okay, which openly bleeds. So the patient will present as will have a melena during the digital rectal examination. So that's why I'm telling the students under me the importance of digital rectal examination. Okay? You will not know that if your patient is having melena until you perform digital rectal examination. Aside from that, during your digital rectal examination, okay, you will palpate and see external hemorrhoids, okay, hemorrhoidal plexus. Okay? So this is another sign that your patient is having portal hypertension. Aside from that, you could also see caput medusa in the abdomen. Okay? Let's go to the other blood supply of the liver, which is the hepatic artery. So the hepatic artery is part of the portal triad and follows segmental anatomy. The hepatic artery delivers approximately 25% of the blood supply and the portal vein approximately 75%. So the hepatic artery arises from the celiac tract, which gives off the left gastric, splenic, and common hepatic arteries. So anatomy na naman guys, ano? So the common hepatic artery then divides into the gastroduodenal artery and of course the hepatic artery. Okay? The most of the time the right gastric artery originates from the hepatic artery, but this is variable. It doesn't follow every time. Okay, let's go to the hepatic vein. Okay, unlike portal vein, hepatic vein is truly a drainage. Okay, it drains the blood from the liver. So the hepatic vein composed of three: the right hepatic vein, the middle hepatic vein, and the left hepatic vein. Okay, so the right hepatic vein drains segment 5, 6, 7, and 8. Okay? While the middle hepatic vein drains segments 4A, 4B, 5, and 8. While the left hepatic vein, it drains segments 2 and 3. How about segment 1? Okay? Segment 1 is special because it is drained by small short hepatic veins which enter directly into your inferior vena cava. Special yung segment. Okay, this is another picture of your liver with the following hepatic vein showing you the inferior vena cava, right hepatic vein, middle hepatic vein, left hepatic vein. Okay, the green one is your biliary tree. Okay, this is your portal vein and the hepatic artery. So most of the time, the portal triad uh, has the same direction, okay, follows same direction. Okay? Okay. So how do we test the function of the liver? Okay? So first, we test the synthetic function of your liver. So more accurate measurement of the liver synthetic function is provided by serum albumin and prothrombin time. Okay? These two are the lab tests that you will request in order to accurately measure the liver synthetic function. But if you are asked, if you will choose only one, okay, you will request coagulation function because this is the single most sensitive test of the liver function. Okay? So coagulation function, you request for prothrombin time, okay, which used to measure the adequacy of the extrinsic and common pathway of clotting mechanism. So if we request for prothrombin time, what are the clotting factors that we test? Edgar. Hello, Edgar. Let's see, Edgar.
Yes, no.
Okay. What are the clotting factors that your prothrombin time tests?
Uh, 2, 5, 7, 9, 10, and 11.
Okay. Partly correct. Okay. It measures factors 1, which is fibrinogen. Factor 2 is neurotrophil. Factor 5, 7, and 10. Okay? So, 5, and 7, 10 common pathways yun, di ba? So, these are the different clotting factors that we test if you request for prothrombin time. So, uh, when you take look at prothrombin time test result, okay, the more important thing to look at is the INR. Okay? The normal INR value is, if it's closest to 1, it is normal. Okay? If your the result is very close to 1, that is normal. Okay? If it's 1.5, okay, 1.5 is the limit that you will that your patient is fit to undergo surgery. Okay, 1.5 is the value. If it's above 1.5 INR, okay, you cannot perform surgery to your patient because definitely your patient will bleed. Okay, so other synthetic factors, as I've said, coagulation, aside from coagulation, albumin, acute phase protein, cytokines, bile, bilirubin, should I say. Okay? So these are the synthetic function of your liver. Okay, so these are the if you will evaluate the liver, these are the following that you will uh, you will test. Okay, the liver function. Does your liver have parenchymal injury, or if biliary obstruction present? Okay? So test of liver function, we already talked about that, synthetic function. Parenchymal injury. Okay, how do we test parenchymal injury? Okay, so hepatocellular injury in the liver is usually indicated by abnormalities in levels of the liver aminotransferases, which are AST and ALT. Okay, so if we are talking about parenchymal injury, hepatocellular injury, we request for liver aminotransferases. Take note of that, which are AST and ALT. Okay, those two. But if you're talking about, if you want to know that if there's the presence of biliary obstruction, okay, what test do we have to request? Okay. So the test here is we request for imaging, like your ultrasound. Okay, we could see biliary dilatation there, which is a sign that there's a biliary obstruction. Other one is MRCP, okay, which is the more accurate uh, radiographic test in if you want to know if there's a biliary obstruction. Okay, let's go to the radiologic evaluation. So first, ultrasound. So ultrasound is readily available. Almost every hospital, I think, have already ultrasound. Okay. So why do we have to request for ultrasound? ultrasound, we could identify biliary duct stones and intrahepatic biliary dilatation. In some ultrasound, special ultrasound, we could already uh, evaluate if there's cirrhosis, fatty infiltration, cirrhosis, meaning uh, these are the ultrasound elastography. Okay, so this is a special ultrasound that evaluates the presence of cirrhosis. Okay, it evaluates if the cirrhosis is as macronodular, micronodular, like that. And ultrasound also differentiates solid from cystic tumors. That's more important also. And it ultrasound is also used in the screening of high-risk populations for AIDS. So screening, what's the meaning of screening? Are you aware what screening means? Screening meaning the patient has no signs and symptoms of a hepatocellular CA, but they are at risk because of some risk factors, okay, which we will talk about later. Okay, ultrasound has also Doppler, which checks for the patency of major hepatic vessels and tumor vascularity. That's important also. And of course, during our surgery, if we are about to perform, if we will perform a hepatic resection, or if we will resect the tumor, we have to locate it because sometimes the tumor is within the liver, which is not uh, it's not obvious, which is you cannot see the tumor by inspection alone. Okay, we have to make use of intraoperative ultrasound in order to locate the tumor within the liver. Okay, that's important also. That's the importance of intraoperative ultrasound. Okay, then we could also map the lines of resection and okay, most biopsy today we make use of ultrasound. Okay, the gold standard nowadays is an image guided biopsy. We don't do biopsy uh, nowadays blindly. Okay? We make use of ultrasound because the yield is much higher if we perform the biopsy together with ultrasound. Okay, this is an example of an ultrasound. Okay, in this part, okay, so the ultrasound shows the right hepatic vein. Okay, the black or anechoic fluid containing structure is the right hepatic vein. Okay, if you will do the ultrasound with Doppler, okay, so if you perform the ultrasound with Doppler, we are almost sure that this is the hepatic. Okay, on the right side is the ultrasound picture of a simple hepatic cyst. Okay, it is also anechoic, meaning fluid containing structure, but you can see the right posterior acoustic enhancement. Okay, so that's a pathognomonic ultrasound findings of a simple hepatic cyst. That's a posterior acoustic enhancement. Okay. Okay, the next imaging that we will talk about is the computed tomography scan or CT scan. Okay. So, CT scan is highly sensitive. We make use of a contrast medium. if we request for CT scan, because similar densities of most pathologic liver masses are differentiated from the normal hepatic parenchyma. Okay? So a CT scan with a dual or triple phase bolus of intravenous contrast agent is performed to achieve the greatest enhancement of contrast between normal and pathologic tissues. Okay, so how can we differentiate normal pathology by make by giving this intravenous contrast agent? Irene. Si Irene, nandiyan na si Irene. So if you're talking about liver, the proper term in requesting for a CT scan is you request for a triple phase. Sometimes it's uh, four phase. Sometimes it's four phase. CT scan of the liver. So Irene, how do we differentiate a normal from a pathologic issue? Or let's just say, how can you differentiate a benign from a malignant tumor by using this triphasic CT scan? Irene? Present ba si Irene? China? Wala siya. Naku, natakot nata. Si ano na lang, si Alvin or Edgar. Kahit sino sa inyo. Sinong nakakaalam nito. Basta wag sa'yo magpasmart. Alvin. What's the importance of these arterial, portal, and delayed phases of CT scan? Alvin or Edgar? Based on your readings, ano, nalaman niyo? Edgar. Si Edgar. Sumagot na si Edgar kanina.
So,
Okay, sige. Okay. As previously noted, the portal vein supplies 75% of the blood flow, di ba? While the remaining is the hepatic artery. So, normal, portal vein ang blood supply. However, in many liver tumors or in many malignant liver tumors, majority of their blood supply is from the hepatic artery. Okay? So, if we will take a look at the arterial phase, meaning the arterial phase is where the venous can be seen at the hepatic artery. Okay? The contrast can be seen because of the hepatic artery. Okay? There's an enhancement. Okay? The classic findings of an hepatocellular carcinoma is there's an enhancement during arterial phase, but during portal phase and delayed phases, there's a distal washout of the contrast. Meaning, the tumor's blood supply is coming from the artery, hepatic artery. Okay? That's the reason for that. That's why during this triple phase, there's an enhancement during arterial phase, which is a pathognomonic CT scan findings of hepatocellular carcinoma. Okay? So the smallest detectable lesion in CT scan is 1 cm. Okay. This is an example, a sample image of a CT scan. On the left, you could see an anechoic, multiple lesions in the liver at the same time in your kidney. Okay? the right picture, you can see a very large cyst, hepatic cyst in the right lobe, anechoic also. Okay? So these are example picture of a CT scan with hepatic cyst. Okay, in the figure A, during arterial phase, there's an enhancement. Will circumscribe brightly enhancing lesion in segment 4 and 5. But during the portal phase, the lesion is isodense. You cannot differentiate it with the normal parenchyma. Okay? That means the tumor, the blood supply of the tumor is coming from your artery, hepatic artery. Okay? This is focal nodular hyperplasia of the liver. Okay, CT scan also is a very useful tool in pre-planning. Okay, because in CT scan uh, we could compute for the future liver remnant, meaning we could compute the amount of liver that will be left after hepatic resection. Okay, actually that's the most important thing if you will perform a hepatic resection. If you have enough future liver remnant that will sustain the function of the liver, okay, that means your liver tumor is resectable. Okay. We could also assess the hepatic vessels and, as I said, the measurement of the liver volume. So we could also evaluate the remainder of the abdomen. There's the presence of peritoneal disease, portal lymphadenopathy, and other remote lesions, meaning there's already a distant metastasis. So MRI, okay? So MRI provides additional tumor characteristics, but it is less accurate in detecting colorectal liver mets. But it is sensitive in detecting early hepatocellular carcinoma. Okay? We could also evaluate the biliary tree, intrahepatic biliary tree, by this magnetic resonance cholangiography, okay, cholangiopancreatography, which is also known as MRCP. Okay? The left picture is the MRI image, but on the right picture, okay, we could see the biliary tree. This is your MRCP. Okay, so we could evaluate the biliary tree. In this picture, the biliary tree is not dilated. At the same time, we could also visualize the pancreatic duct. Okay. This is the right picture is your MRCP. Okay, let's proceed with the infection of the liver. Okay, so there are two main infections of the liver, namely the pyogenic and amoebic. Okay, in your pyogenic etiologies are acute appendicitis, impaired biliary drainage, hematogenous, and endocarditis. While for your amoebic, okay, the etiology is the amoeba histolytica. Okay. For the location, okay, the pyogenic most of the time is located at the right lobe. Both pyogenic and amoebic could be single or sometimes multiple. Okay, in amoebic uh, infection, most of the time there's also the necrotic central portion. Okay, both infection will have a symptoms of right upper quadrant pain, fever. In pyogenic, okay, jaundice is common, unlike in amoebic abscess. jaundice is unusual. So these are the comparisons for the two. Lalo naman. Okay. So this is a sample picture of a CT scan. On your left is your pyogenic abscess. It shows enhancement of the walls. You see, so see properly the capsule of the abscess. Okay, in doing your culture of your liver abscess, the yield in pyogenic is 50%. Well, for amoeba, we should also request for your fluorescent antibody. It's an enzyme immunoassay. Antibiotics, okay. So the most common question here is, what is the antibiotic drug of choice for your anemic abscess, which is metronidazole, 750 milligrams, 3 times a day for 7 to 10 days. Drainage, okay, we could perform laparoscopic, open, or percutaneous drainage in pyogenic. Well, for amoebic abscess, aspiration rarely needed except for large abscess. Okay, so how large is the abscess? The cutoff here is you could perform aspiration if the abscess is more than 5 cm, but if it's more than 10 cm, okay, you should also you just don't do it aspiration. You put an indwelling catheter also, okay, in order to drain the remaining abscess. Okay, so I got this algorithm in your book, Schwartz. So if there's a mass identified incidentally by ultrasound or CT scan, of course you have to get your history and perform your physical examination. Then laboratory tests, these are the following. Then you have to perform, you have to request for additional imaging. If the initial ultrasound is if the initial imaging is ultrasound, okay, you have to request for CT scan or MRI. Then, okay, so if CT scan, if a CT scan or MRI was done, if it's necessary, you request for biopsy. But most of the time, CT scan, the triphasic CT scan or MRI scan will tell you already what the tumor is without doing your biopsy. That's how good the CT scan, triphasic CT scan is. The, the CT scan will already commit that the tumor is cellular, age, adenoma, and so on and so forth. Okay? So liver biopsy is rarely done because if you perform liver biopsy, could of course your liver might bleed, or sometimes okay, it could also induce metastasis to the needle that you insert in your liver. Okay, let's go with the liver lesions. Okay, so we classify liver lesions benign and malignant. These are the following benign liver lesions. On your left and on the right are your malignant lesions. Okay, let's go first with the benign. Okay, most common. Okay, benign tumor is liver cyst. Okay, most of the time it is congenital. Okay, and I see a lot of patients with polycystic liver disease. the same time, the renal also has polycystic. Okay? So, uh, the main, the definitive treatment for polycystic liver disease is liver transplant. But if you want to, uh, because liver transplant, that transplant will cost you 10 to 15 million if your patient cannot afford it. The alternative treatment here is you can do unroofing of the large cyst. Okay, so remove as much as you can in polycystic liver disease. Okay, so these things are in your Schwartz. Okay, so my lecture, the purpose of my lecture is just to guide you what are the important things, overview of the liver. Okay, but I encourage you to read the book, your reference, which is Schwartz, in order to know more about liver. Okay? Walnut hamartoma. Okay? These are small liver lesions measuring 2 to 4 millimeter. So the treatment here is incisional biopsy. Okay, hemangioma. Actually, this is the most common benign tumor. Benign, okay? Benign liver tumor. Okay? So, is there a malignant transformation? It's controversial. Actually, hemangioma, uh, most of the time, we live with, okay, there's no need for surgical resection. But if it's very big, okay, pending rupture is imminent, so we perform resection of the hemangioma. But most of the time, we leave the hemangioma alone. We don't do resection most of the time. Next is adenoma, which is common to young women. Okay? So, if you will get the history of your patient, most of the time there's a prior or current use of OCP. Okay? These are pills. Okay? Okay, if you perform the CT scan, there's a sharply defined border confused with metastatic tumors. Okay? So the current treatment for adenoma is we do resection. Another benign tumor is your focal nodular hyperplasia, which is common for the childbearing patients. There's also a history of OCP use, and most of the time, your FNH will rupture. There's no also significant risk of malignant transformation. Okay, so in CT scan, the typical findings is there's a well-subscribed typical central scar with intense homogeneous enhancement during arterial phase. Okay, just like the one, the picture I showed you a while ago. During arterial phase, there's an enhancement of the tumor. But during portal phase, you can already see the tumor because you cannot differentiate it from the normal parenchyma. So the main indication for surgery is abdominal pain. Okay, then you ask your patient to stop using OCPs. Okay, let's proceed with the malignant liver tumor. Okay, question muna tayo. Aldwin, if in the exam I ask you what is the most common liver tumor? Aldwin, what's your answer?
The hepatocellular carcinoma.
Hepatocellular. How about Edgar?
And
hemangioma.
Hemangioma. Okay. So my question is, most common liver tumor, be it malignant or benign. So your answer, Alvin, is hepatocellular, right? For Edgar, your answer is hemangioma.
Yes, Doc.
Okay. Actually, the most common liver tumor is a metastatic. Okay, metastatic liver tumor is the most common liver tumor. But if the question is the most common benign tumor is hemangioma, and if they ask you what is the most common primary, the keyword there is primary malignant liver tumor, the answer is hepatocellular carcinoma. Okay? The keyword there is primary. Okay? So in hepatocellular carcinoma, the risk factors are viral hepatitis and alcoholic hepatitis. Viral hepatitis meaning hepatitis B and C. Okay. The typical CT scan findings of ACC is enhancement during arterial phase and washout during delayed portal phase. Also in MRI, there's a variable T1 and a hyperintense T2. Okay, so this is the algorithm for HCC which I took in your Swartz. Okay, so for resection, your patient should be non-cirrhotic with a child's A. Okay, so later on we will talk about child Q scoring. It should be single lesion with no metastasis. Okay. Is your patient candidate for transplant? Okay. If there's a one lesion, it should be less than 5 cm. But if there's 3 lesions, it should be less than 3 cm. Okay. Indication active for liver transplant is if your patient has cirrhosis. Okay. That's why you can see charts A, B, and C. Your patient has cirrhosis and the tumor is small. Okay. That's the indication for transplant. But if the tumor is not a candidate for resection at the same time for liver transplant, we could do sorafenib. We could give sorafenib, TACE, and other systemic adjuvant treatment. Okay. Okay. Next thing is cholangiocarcinoma. It's the second most common primary tumor of the liver. Okay. We could also encounter this cholangiocarcinoma if we will know about the biliary tree. Actually, cholangiocarcinoma is a cancer, true cancer of the liver. Okay. The most common classification, type of cholangiocarcinoma is your Klatskin. And we could do, the treatment is surgical resection with porcel-bimal if there's already a vascular increase. Okay, let's go with the metastatic colorectal carcinoma. Okay, so this is the most common tumor, whether it's with the most common liver tumor. Okay, so it has a 10-year survival based on 6 events. If the segments are 4 or more, it's 29%, but if it's solitary, it's already 33%. So a while ago, I told you about the future liver remnant. So because resectability is no longer defined on what actually is removed, but on what will remain after resection. If the future liver remnant is sufficient in order to sustain the function the liver, it is considered resectable. Okay? So other treatments could do adjuvant chemotherapy, portal vein embolization. If your liver remnant is not sufficient, we have to uh, induce the remaining liver to a hypertrophy or hyperplasia. Okay? Then we could also simultaneous ablation, okay, meaning radio frequency ablation together with your resection. Okay, so the gold standard still for metastatic colorectal carcinoma is hepatic resection. Okay, with a margin of 1 cm. Okay, so this metastatic colorectal carcinoma, so it's a colorectal cancer stage 4 already. Okay, this is the only stage 4 that we can achieve cure or treatment of the patient. Okay, back in the days, if you have already colorectal stage 4, okay, you you cannot perform curative treatment already. Uh, with the help of research, okay, we already know that even if your colorectal cancer is stage 4 with the liver mets with already a liver mets, the, your treatment is the intent of your treatment is still curative, okay, not a palliative one. Other treatment for malignant metastatic colorectal, we could perform radiofrequency chemoembolization as well as chemotherapy. Okay, let's proceed with acute liver failure. Okay, so what are the etiologies? Viral infection, the hepatitis A, B, and E. Drug-induced acetaminophen. Okay, so common to acetaminophen sulfates. So what are the clinical presentation? Jaundice, encephalopathy, hepatic coma, increased creatinine, arterial pH less than 7.3, and a culture-proven infection. So you could do your liver biopsy in order to diagnose this liver failure. If you know already that the main cause of your liver failure is due to acetaminophen, you could give activated charcoal or an acetylcysteine. Okay, let's proceed with cirrhosis. So cirrhosis can result from a wide range of disease processes, including viral autoimmune, drug-induced, alcohol-induced, non-alcoholic fatty liver disease, and metabolic diseases. But the most common cause of chronic liver disease worldwide, okay, this is worldwide, is NAFLD. So what is NAFLD? It's non-alcoholic fatty liver disease. Okay, so NAFLD or non-alcoholic fatty liver disease is now the most common chronic liver disease worldwide. While for your NASH, non-alcoholic steatohepatitis, is a progressed form of NAFLD characterized by steatosis with hepatocellular injury and chronic inflammation. Of course, you have to get your history, perform your physical examination. So during lab test, you will see mild normochromic anemia, low WBC and platelet. If you do your bone marrow aspiration, you will see macronormoplasty. If you request for your protein, okay, you request for protein because you want to know the synthetic function of your liver, and it is deranged, it doesn't respond well to a vitamin K. If you give, even if you give vitamin K, it does not respond. Okay, fortunately, it does not respond. phosphates for your bilirubin, transaminases, again, transaminases are elevated if there's already a parenchymal injury. The same time as alkaline phosphatase, these are all elevated. So we request for liver biopsy, ultrasound CT guided, in order to diagnose cirrhosis. Okay, we mentioned a while ago the Child-Purge score. Okay, it has 5 parameters: your bilirubin, albumin, INR, encephalopathy, ascites. Okay, if you compute for the scoring, okay, Class A has 5 to 6 points, Class B 7 to 9 points, Class C 10 to 5, 10 to 15 points. The importance of this transfer compute in order to classify the liver cirrhosis. Okay? So Class A is normal, but Class B and C, you have already a severe cirrhosis at this point. So surgical resection is not advised. Okay? If you have Class B and C, the treatment here is already a liver transplant. Okay, lastly, okay, this is my last slide. Last, we talk about the portal hypertension. Okay? These are the signs and symptoms of portal hypertension. The patient does have gastroesophageal varices, splenomegaly, caput mendozae. Okay, if you look at the abdomen, ascites already, and rectal varices. The treatment is OLT, is orthotopic liver transplant. Tips, okay? If, if, if they ask you in the exam what is the treatment, okay, most commonly the answer here is tips. Okay? Shunt, we don't do shunt nowadays. Even if it's in your book, we don't do shunt nowadays. The treatment here actually is portal hypertension is tips. Edgar, alam mo yung tips? Aldwin,
Transjugular intrahepatic or
tips, yung pag nasa restaurant ka. Hello? Aldwin? Yes, Aldwin.
Transjugular intrahepatic portosystemic shunt.
Okay, good. Good tips. Okay, so that's that's my last slide na talaga. Yan. Okay? So that's the overview of the liver. Okay, but most of the important things we already talked. Okay? Any questions? China, do you have question? Hello? Simple lang, ano? Dali lang yung liver, no? Simplified. Ito yung simplified lecture ng liver. Okay? Si Chilon, nandiyan ba si Chilon?
Good afternoon po, Doc.
Yes, Dr. Abalos. Any question? Clarification?
Kati Marian po siguro, Doc.
Si Marian. Marian, musta sa Baguio?
Hello po daw, good afternoon.
Hello, good afternoon. Di ba taga Baguio ka, Marian?
Yes,
Musta sa Baguio? Pwede na pumasal?
pwede naman siguro.
Any question, Marian? Any
Wala
question?
po.
Wala. Sige. Okay, if there's no more questions, clarifications, okay. Or message nyo na lang ako pag may tanong kayo, di ba? Most of you are my friends in Facebook, or you could add me in your Facebook. Okay, if you have questions. Parang may nag-chat. Thank you. Okay. So, that ends our lecture for today. Okay. So, for my group, okay, Shaina, we will have our work for tomorrow. Anong time, Shaina, bukas? Afternoon, di ba?
Yes, po. 3 to 5.
Okay. 3 to 5. Okay? So, thank you guys for listening to my lecture and have a good day. See you guys tomorrow, Shaina. Bye. Thank you guys.